Hi, this is Brian Kim. I'm going to share with you this case of a patient who has a visually significant cataract, but she also has penetrating keratoplasty in this eye. Actually, she had a penetrating keratoplasty in the other eye as well and did very gentle cataract surgery technique, but despite my best efforts, her cornea decompensated, so I had to do a desec on top of her PKP. And so she did quite well from that, but she is understandably quite apprehensive about having cataract surgery on this eye. And so I'm going to show you the techniques that I use to minimally traumatize the corneal endothelium, to be very gentle, be very safe, stay away from the cornea, and using mechanical fracturing techniques and chop techniques in order to do this. So you can see this patient has a corneal transplant. I'm using a cotton tip to help center the eye, and then I'm using a corneal marker to help hopefully get me a nice central and good sized rhexis. I'm using the cotton tip to hold the eye. I'm making my paracentesis, and I'm trying to make sure I don't get into the graft. And so when I make my incisions, I make sure I stay very clear from the graft because I don't want to abut against the graft and cause any potential problems there mechanically or with the fluidics. I don't want to allow my manipulation to get near the corneal transplant. So I inject some intracameral lidocaine and then some dispersive viscoelastic. And then I'm going to do my triplanar corneal incision and make a vertical groove. Turn the eye away from me a little bit. Place the blade into the deep part of the groove. Again, I don't want to go near the graft, so then I dive down, and that's the triplanar corneal incision. And I'm able to get a really nice shelf, and again, it's pretty clear away from the graft. I turn the teeth sideways, go in for my puncture-style Capsulorhexis. I puncture with the forceps, I pull downward. You can see the zonules are a little bit weak here, and that's another thing is patients who've had prior surgery, sometimes they can have that weak zonule effect, and so I'm prepared to put in a 3-piece lens. So going around circumferentially, grabbing and re-grabbing. So I'm using the corneal marks to help me center and size the rhexis. So go ahead and finish off the rhexis and then burp some viscoelastic out. And this is a capsular fornix hydrodissection technique. I place the cannula underneath the anterior capsulorhexis edge, contra-incisionally, point the tip down, get a nice fluid wave, decompress on the left side, and then I spin the lens from the right side. I'm going to lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Again, I'm making sure my instruments are not near the graft at all, including my chopper. I remove the surface epinuclear material, place the chopper out to the equator, turn the phaco tip vertically, crush the lens in half. That's the double chop. Place the chopper out across the contralateral equator, pull it centrally toward the phaco tip, crushing the right heminucleus in half. That's the cross chop. I use a little bit of vacuum to pull the lens piece up, place the chopper around the lens piece, crush it and divide it in half, and then using mechanical fracturing forces to sandwich the lens pieces. That's the first quadrant that's been removed. Place the chopper around the second quadrant, pulling the lens piece up, crushing it with mechanical fracturing forces, and then emulsifying the lens pieces. I'm turning the second heminucleus in front of me, place the chopper out to the equator, pull it centrally towards the phaco tip, crushing the lens in half. Now I'm placing the chopper around the third quadrant, pulling it up out of the bag, crushing it with mechanical fracturing forces, and emulsifying the lens pieces. Place the chopper around the fourth quadrant, and then using vacuum, pulling that fourth quadrant up, and then emulsifying the lens pieces. You can see the CDE is very low, and I'm making sure all of my manipulation is at or below the iris plane. I'm removing the epinuclear material, making sure the chopper is deep to protect the posterior capsule. So I take the chopper out, push BSS in, take the phaco tip out, and then go in with the INA handpiece. I'm starting subincisionally, sweeping side to side, making sure I get the cortical material. peeling it from the anterior side towards the posterior side. I'm going around circumferentially. That was actually a very thin layer of epinucleus, so I removed all that. And I'm going back, sweeping side to side, removing the cortex. Going back subincisionally. Switch to the polish mode, and I'm polishing pretty aggressively underneath the rhexis edge, removing the lens epithelial cells and cortex. So you can see the CDE is fairly low, and all the manipulation has definitely been away from the endothelium. I can see there's a very nice, robust layer of viscoelastic still coating the cornea. I'm polishing the posterior capsule surface now, going in with VSS cannula, pushing it into the subincisional capsular fornix, making sure there's no cortical material there. Looks pretty clean. Now I'm injecting some cohesive viscoelastic to fill the capsular bag. Now I'm going to polish underneath the anterior capsulorhexis edge with the sweep, first on the left side. And then now on the right side. So like I said before, any patient who's had prior intraocular surgery, I do think those patients tend to have weaker zonules. And so because she's had a PKP, I went ahead and decided to use a 3-piece lens. I'm widening the incision with a paracentesis blade for my 3-piece lens. I'm able to place the barrel through the incision. I have the bevel facing to the left. I'm injecting the lens haptic. The leading haptic is facing to the left and it goes into the bag. And I rotate the barrel in such a way that the optic comes out planar. I deposit the trailing haptic into the bag using the Maltzman. I go in with the INA underneath the optic, tilting it and removing the viscoelastic from the bag. And then I'm removing the viscoelastic from the anterior chamber. You can see there's a really nice thick layer of viscoelastic still coating the corneal endothelium. I tried to do this case as gentle as possible, again, making sure my incisions don't abut the graft area, making sure my main incision was far away from the graft area as well. If I didn't have as much real estate, I was prepared to make a scleral tunnel if I needed to. So as I remove the INA, I push BSS in, and then I hydrate my incision. So I'm happy to say this patient ended up 20/30 uncorrected post-op day 1. She was very happy and relieved that the cornea was nice and clear, and she was able to see. I had her use a lot of steroids before, and she will continue steroid drops intensively after surgery to help keep the health of that transplant that she has. Again, I use double chop, cross chop, mechanical fracturing techniques, minimized ultrasonic energy use, made sure all the manipulation was below or at the iris plane at a minimum, kept all the manipulation away from the endothelium, made sure my incisions were away from the corneal tissue. And so this patient thankfully did quite well after this cataract surgery. So I hope this was helpful to you, and I thank you for your attention.